Now, coming to conventional sternotomy, you make an incision from the sternal notch to the Ziffy sternum, which is about 12 to 15 centimeter. Then came the partial sternotomy, where you make the incision just above the nipple to the Ziffy sternum. This is about 8 to 10 centimeter. Then came the lower mini sternotomy, where you make the incision just below the nipple up to the Ziffy sternum, where you make a 5 to 6 centimeter incision, or a upper mini sternotomy, where you make incision just above the nipple to the sternal notch. Again, this is 5 to 6 centimeter. These are all various incision for sternotomy. Coming to thoracotomy, you do a right thoracotomy, which is for mitral valve surgeries and ASD closure. Left thoracotomy, where you can do coronary artery bypass grafting, or you do a mini thoracotomy. The incision normally, which is about 10 to 12 centimeter, will be reduced to 6 to 8 centimeter. This you do an uncomplicated ASD closure. Then you can have a long bilateral thoracotomy for the surgeries where heart is enlarged, or you do a submammary or inframammary approach, particularly in young females. These are all various thoracotomy approach to cardiac surgery. Coming to recent approaches, you have port assisted surgery, particularly in thoracic surgery, or image guided hybrid surgery, which is used in vascular surgery, or robotic surgery, where coronary revascularization and mitral valve repair are being attempted. I will be talking about a modified approach, which is Zufsifoid sternotomy. You make at least 3 to 4 centimeter incision just below the nipple, and you also make a 1 to 2 centimeter thoracotomy incision for placing the inferior vena cava cannula. So, what are the various factors which are helping us to do minimally invasive surgery? The first and foremost is a good pre-op workup and optimizing the patient to the maximum. This helps not only in doing the surgery, but also helps in fast tracking the patient. The next most important variable is the experience of the surgeon as well as the anesthesiologist, and the wavelength of the anesthetist and the surgeon should match. Third important component is, even though you do minimally invasive, it should be accessible to all the structures of the heart. So, in case any complications or any problem happens in the perioperative period, you should be able to deal with it, and specialized equipment should be available so that the surgery can be done neatly. Coming to the anesthetic factors, the first and foremost is going to be use of transesophageal echocardiogram. Here, the echocardiogram helps in the assessment of the cardiac function and adequacy of the repair, whether the repair has been perfectly done. Another important thing of transesophageal echocardiogram is your placement of SVC, IVC cannula and the aortic cannula. The anesthetist can guide the surgeon to place the cannula in the great vessel. Whenever you do thoracotomy, you have to go for own lung ventilation. This will be really challenging in a sick patient. Already the patient might have pulmonary edema or the lung might be compromised, and isolating such sick lung will be really challenging for the anesthesiologist. And whenever you do thoracotomy, the patient will be in a semilateral position. So, you have to adjust the arterial line and IV line according to the position of the patient. Adequate analgesia, anesthesia, and most important thing is muscle relaxation. There should be adequate muscle relaxation, because the muscle has to be pulled apart nicely so that the surgeon can access the respective part for repair. Finally, after doing minimally invasive surgery, we have to fast track the patient. These are all the anesthetic part of minimally invasive surgery. Coming to surgical issues, there should be adequate exposure in spite of the incision being minimal. The most important thing is mode of cannulation to aorta and access to the both superior and inferior vena cava. Once the access is done, effective myocardial protection should be done. Then adequate repairing. Once repair is done, good de-airing should be done. These are all the surgical steps which is required for minimally invasive surgeries. Coming to perfusion part, try to avoid hypothermia, use modified ultrafiltration so the inflammatory mediators come down, use low priming volume cardiopulmonary bypass circuit, and always be safe. Safe application of cardiopulmonary bypass. If cardiopulmonary bypass is established in a safe manner, 90% of the job is